My name is Mikel L. I'm also delighted to be here. Appreciate the invitation. Learned a lot in this meeting. The high points has been an amazing educational approach. Advocate it strongly. So again, AI-generated objectives. I'm going to do my best to hit the highlights of these. And we're going to talk about something that I think is an important point, particularly for an APP to speak about, because again, chronic indwelling catheter management, really mainstream urologic practice. It is normally done by nurses and advanced practice providers. Notice, I'm a clinical consultant with Coloplast. They have nothing to do with indwelling catheters. They're very involved in intermittent catheterization. About 5 million patients are catheterized annually. 25% of patients in hospital have an indwelling catheter. The 5 million data actually indicates properly that they are going to be wearing a long-term indwelling catheter, 30 days or longer. 600,000 patients at any given point are going to have an indwelling catheter in. And if you look, it's really down from previous years, but just a little over 7% of individuals living in skilled nursing facilities and related long-term care, as well as post-acute care, are going to have long-term indwelling catheters. So the first thing, of course, is always catheterize only when necessary. Question the need for indwelling catheter when evaluating the patient for the first time. These are largely, this is indications I've pulled from several sources, including the Center for Medicare and Medicaid Services, the F315 guidance to surveyors in long-term facilities. And again, you get an idea that unless the patient has obstruction plus some sort of incomplete bladder emptying, if you're trying to heal a full thickness pressure injury or some sort of wound in the perineum or bladder management in the palliative care setting, what we have to add on to that, and if you look at guidelines from overactive bladder guideline to multiple others, you'll also find that indwelling catheter is a legitimate last resort, emphasis on last resort, bladder management strategy in extremely highly selected cases. Normally, you're going to get to that last resort when palliative care or end-of-life care intersects with your management of your patient. So the first thing I want to advise you as urologists and as APPs would be to look at the catheter itself, be familiar and be comfortable with the product itself. Look at the substrate, look at the coatings, at least be aware of some things about the retention balloon. Of course, we all look at French size or Charrier size, look at the catheter tip, and look at the drainage system. There are 3 basic substrates or materials that these catheters are made of. The first is latex, second is silicone. Polyvinyl chloride, largely relegated to intermittent cath. I'll talk about the first 2. Latex is inexpensive, it's easy to mold, it's easy to produce. It has wonderful balloon performance. Those balloons will go down, the catheter is easy to remove. Silicone has been touted very much as entirely 100% biocompatible. It is relatively biocompatible, far more than latex, far more than latex. However, there are 2 myths that often get applied to silicone. Number 1, it does not prevent incrustation and catheter blockage. It reduces that process. It will buy your patient a number of hours. The hours in every study that I could find published were less than 24. Number 2, silicone balloons do not perform as well as latex balloons. When that balloon is deflated, it will often create a cuff. Your nurse or your APP will go to pull on that cuff. Your MA perhaps will go to pull on that cuff. The catheter cannot be pulled out easily. And there's a lot of urban myths about things to do. You already know what to do as well as I do. Put a couple, 2 to 3 mLs in that. You gently pull that out. But I will tell you that even with that 2 to 3 mLs in that balloon, it does create a more painful catheter withdrawal. So just be aware of the substrate that you're choosing as well as some of these other features. Now, coatings are very interesting, and coatings have been something that have really done a good deal for us. If you look way back in the 1980s, when I was getting started in my practice, This is before there were really good, even Teflon-type coatings or the polytef type coatings. And what you found was that if you put an indwelling catheter in, there was a growing inflammation around the urethra. The glans penis in the male would look like a little bomb. It exploded there. And the discomfort really evolved over days because of that. Initially, polytef, which is a little bit rough on the urethra, and more importantly and more recently, hydrogels and hydrophilic polymers, which allow a limited amount of absorption, not just to bulge it up, but a limited amount of absorption. I'm not going to go over a lot of this other stuff. I will tell you that the antimicrobials and the inox silvers and all these type things that I'm listing at the bottom, they will give protection for a number of days and not much beyond that. The other things are called anti-fouling coatings, and they do have some benefits, but it's nothing that we need to spend a lot of time on. Obviously, in terms of the retention balloon, again, many nurses in particular are absolutely persuaded by the urban myth that if a 10 ml balloon the patient has difficulty retaining that, then the 30 ml balloon is going to be just much better. And we all know that that is not the case. With a 30 ml balloon, there's going to be greater retention of urine in the base of the bladder. In terms of the diameter, again, this idea that bigger is better. Many of us see urethras that are going to eventually erode because the 14 becomes a 16, the 16 becomes an 18, the 18 becomes a 20, then it becomes a 20 to 30 ml balloon, and so on and so on and so forth. This will set your patient up for erosion. What about tips and drainage systems? Well, obviously you know this as well as anyone, but I just remind you that do choose a tip carefully, and if you're choosing a tip, be sure that your staff has been educated on its insertion. I am amazed sometimes when I go in and I see an individual trying to be catheterized with the coude tip and the bump folded down, okay, as if it were going towards the floor instead of the ceiling. Very simple things like this, these types of selections. I know that when you think, I'm going to write an order, let's put an indwelling catheter in, I'm sure the nurses will take care of that. They are going to do their absolute best to follow up and take care of that for you. But your selection and your careful thoughtfulness to which is the best catheter for the right catheter, the right patient, the right time, that's going to make a good deal of difference. There is a lot of science behind the drainage system. I will tell you that nursing education, I'm going to speak a lot to nursing because of my nurse practitioner background. Nursing education is pretty sophisticated with these drainage systems. The idea of using the catheter strap and the various types of leg bands and all that. This is something that has decent penetration. Your staff will be very helpful for you using not only ambulatory bags, but also overnight bags and switching between those two. Okay, again, the catheter straps, there are various designs. I will tell you that we have found there are advances currently in some of the adhesive technology, which is leading to better catheter straps and better catheter securement devices. There's also advancement in various aspects of the actual drainage system design. And one of the most important things, of course, is what we do when we're doing ongoing catheter care. The biggest urban myth that exists, and it's a global myth I've read papers from Canada, from Europe, as well as from the United States, talking about the ideal catheter change is monthly. That is absolutely an urban myth. It is not a factual statement. As it turns out, the monthly tradition has been dictated to us by reimbursement groups such as the Center for Medicare and Medicaid Services. You will have patients who will be on both ends of that. Let's talk about the more frequent change needs. You have a patient who is beginning to develop incrustation. That catheter is getting blocked before the desired 30 days. In that case, again, the one thing that you can do, which we all tend to know about, is you can take that patient and you can say, let's do every other week catheter changes. Let's do more frequent catheter changes. That's perfectly fine. What most nurses will tell you is put in a silicone catheter. I've been told that that will prevent incrustation. It will not. It will just reduce it less than a day. But the second thing that you can do, and there are finally products in the United States, I've been working on this for decades, there are products in the United States that will allow for irrigation of the catheter, 15 to 30 mLs only. It will be a mildly acidic irrigation. It is pre-packaged and made for that, and it can get you another 5, 7 days, maybe even 2 weeks of catheter wear. Finally, there are other patients who do not require catheter changes as frequently as we think they do. For example, these individuals may actually be able to safely go, particularly if you're talking about a latex-coated catheter with good balloon performance and one of the hydrophilic coatings. Remember, your patient's not being automatically exposed to latex. That coating does coat the latex. They can last for sometimes 6 weeks, sometimes even longer, with a very stable and safe catheter change. Okay, so these are things that you can do. Teach a patient to regularly cleanse the genital area. Need I say more? Okay, you look at the catheter and you look at the surrounding genital area, you look at the fecal incontinence in the area, you look at the body-worn absorbent product that's being worn, and you say to yourself, yes, of course you're getting E. coli. I can see the source with my bare eyes. Okay? Avoid application of topical ointments, creams, or antibacterial solutions to the urethral meatus. Again, this is a traditional practice that has been shown in study after study after study to predispose to rather than to prevent. Teach adequate fluid intake based on Institute of Medicine recommendations. In most adults, you're talking a minimum of about 1,700 mLs up to about 2,500 mLs daily. I tell my patients that you must have essentially a running stream and never a stagnant pool. Look at that urine, struggle to get it as close to straw-colored as possible. And finally, this is something that we do quite a bit of, and that is discontinue adrenergic blockers when not indicated. If you have a patient that you're looking at and you're going to continue to do trials, avoid, of course you don't want to do anything with those alpha blockers. But I have patients who have had catheters in for 4 years, and they are on a chronic catheter, and they're still receiving their tamsulosin, blancazocin, whatever it is, month after month after month. It's just simply good patient care. And finally, teach the patient to use and clean, I'm going to say that word again, and clean the drainage system in the long-term setting. Your nurses will have knowledge of this. There are good guidelines of this from the International Continence Society, from the Society of Urologic Nurses and Associates, the EAU and the European Urologic Nurses that talk about how to cleanse that bag and to keep that thing from being this overrun, stagnant pool that is simply not appropriate for patient care. Finally, prevent or promptly manage these indwelling catheter complications. CAUTI somewhat speaks for itself. Basically, when you look at it, and this is Meddings and a nice little systematic review, hand hygiene, intravaginal estrogen replacement in appropriately selected adult women, and finally, increasing fluid intake unfortunately doesn't do it. Cranberry vitamin supplements doesn't do it. Antimicrobial prophylaxis, controversial, probably gives short-term, not so great when you look at it in the long term. Okay, other complications, we've talked about catheter blockage and incrustation. You can switch to silicone, you'll get a matter of hours. You can do these irrigations, you'll get a matter of days to several weeks. Catheter bypassing or leakage around that indwelling catheter. Of course, the first thing you want to do is you want to assess for blockage. It can be clot blockage, can be incrustation. You want to look for bladder spasms, which is your overactivity in my world of urodynamics. Plus, you want to look at urethral erosion. I would remind you, a nice study by Carol Bennett out at UCLA looked at individuals who had long-term indwelling catheters. These were all adult females. 50% had urethral erosion by 5 years in. Okay. Purple bag syndrome, again, it's an adverse effect of constipation. It's not a CUNP. Traumatic, and what is the management? Treat the underlying constipation, traumatic hypospadias, as well as when there is a risk of urethral erosion. This is a point when I would strongly encourage conversion to a suprapubic catheter. Securement also may have some. So what can we summarize out of this? Only when indicated, out as soon as possible. Always question the necessity when you get a patient in your practice with an indwelling catheter. Be knowledgeable about the characteristics of the catheters that you have available to your patients. Take the time to discuss briefly with your nurse, your MA, whoever your practice person is, your practice colleague is at that point, and say, this is a catheter that I want in this patient, given what you've described or given what I've assessed myself. That moment of time is worth your intervention, I promise you. Individualize the change frequency. Work with your staff. See who your crusty catheters are. See who's blocking all the time and see what you can do about those patients. But also be open to the fact that every 30 days is a false construct. And finally, recognize and prevent or promptly manage these complications. Thank you.